Testing 1.
Testing 2.
Testing 3.
Testing 4.
Yeah,
Well,
he's got it.
He's got it. We're in.
Welcome everybody on the Testing podcast, where we talk all things fertility. Today we're joined by a very, very great guest among a racing friend of ours, Dr. Tim Charles. Welcome to our podcast today.
Thank you for having me.
Yeah, welcome.
Yeah. How are you? How's everything your end?
Pretty good. Looking forward to the racing season. Sort of getting going.
We'll definitely get on that today.
From April, so just I'll get that in there early.
Yeah.
But no, I'm sort of been busy this week with some HFEA work and then University of Oxford work, and
I realised actually you can geek out with each and every one of us because you've got motorsport with Toby. You're a bit of a rocker, I hear.
Yeah, got band practice. tomorrow.
Nice. So I'm a
nice
rocker.
link with,
Cool.
And then Science Geek with Mike.
I can't wait. I can't wait for this episode. Yeah, this is going to be a great episode.
We've got to try and keep on track as to what we're talking about. But we were just saying just before we started, you're a man that wears many hats other than racing driver and rock and roll man.
Yeah.
Take us through your kind of career and your hats and what you do.
Okay. So I went to medical school, obviously, as I'm a doctor. And when I was there, I didn't really know what I wanted to do, actually. And I did my clinical part of the medical school at the Royal London Hospital in East London. And I was there between 1990 and 1993, so early days of IVF. And in the obs and gynae rotation, we spent some of that time in the IVF unit. And I was just really taken back by it. To me, it just really opened my eyes. I thought, this is amazing. Working within fertility would be a fascinating thing to get into. Left medical school. I actually then thought maybe I'll be a surgeon, but then didn't really like surgeons. I thought, no, I don't want to be a surgeon. I thought maybe I'll be a physician, but I thought they don't really do anything, just prescribing drugs and that sort of stuff. And I thought, hold on, obs and gynae combine surgery and the medical side of it, and the thinking side of it. And if you go into fertility, you're treating very often a couple, obviously men and women, so it's not just focused on one sex. And so I then came to Oxford. I did obs and gynae training in Oxford, and fortunately the first 6-month job I had was on the team in Oxford that was responsible for the IVF unit. The professor had actually set it up. So I then sort of really from there went into working. I did a research job in IVF, went to Canada for 2.5 years and worked in Montreal, researching maturing eggs in a lab over there. Came back to the UK, got a consultant job in Oxford and an academic job at the University of Oxford, and have really been there since. And then added on to that, then 3 years ago, applied for a position on the board of the HFEA, so the regulator of treatment and research in the UK, which I've really, really enjoyed. More recently, I've left TFP, which was the IVF group that I helped build up from 1 clinic up to 20 clinics, and I'm on sort of a few months sort of gardening leave at the moment with that, but continuing on with the various other things.
Wow, that's a lot, isn't it?
That's a lot. That's
Is that it now? Should we go?
Go down the pub now, it's fine.
So I think the HFEA stuff's quite interesting. It'd be a good one for us to explore, because that's not, we don't get many people from the HFEA that we would know or would bring into a podcast. So I don't know, could you tell us a little bit about, because a lot of patients will know about HFEA, they would have been to the website, they would have looked at stats and the traffic light system and all this, that and the other. So kind of, for those that maybe don't know as much, what are the HFEA responsible
Well, I think to be honest with you, even people working within clinics often have a misunderstanding about what the HFEA is, both good and bad misunderstandings. So in the UK, back in, again, I remember this in the in the 80s, late 80s, there was this epidemic of multiple births from fertility treatments. So, triplet pregnancies naturally are exceedingly rare. And there was just all of a sudden, there were hundreds of triplet pregnancies coming through, very high risk pregnancies. So there were lots of concerns about the wild west of IVF in the UK. So Dame Mary Warnock was asked by Parliament to there was a commission to put a paper together about how this should be regulated. Then there was an act of Parliament in 1990, so the Human Fertilisation and Embryology Act. And as part of that, Parliament said there needs to be an organisation that makes sure that clinics follow the Act, and that's the HFEA. So the authority is there to make sure that clinics and researchers follow the law, i.e. the Act of Parliament. Because people often think the HFEA make up the rules, and they don't. No. What we do is we make sure that clinics follow the law. So that's essentially what the HFEA does, and a big part of the remit is to ensure that patients are protected, are treated properly. Obviously, the donor side of it, the donor anonymity is protected, and what have you. So there's a board of the HFEA called the HFEA Authority, and it's made up of quite a wide, broad groups of people. There's lay people on there. There's normally a couple of IVF professionals. So I'm one. Geeta Nagand is the other person. Then there'll be some embryologists, a lot of scientists on there, and lay people, religious background people, all sorts. So every 2 months we have a board meeting, and it's all people can apply to watch online that as well. It's all minuted. And then in addition to that, I chair part of the HFEA called SCAC, which is all acronyms. So SCAC is the Scientific and Clinical Advances Advisory Committee, which is a fascinating group. There's about 15 people on it. Again, a mixture of medics, embryologists, and really high-level stem cell scientists, with also some lay people as well. And as part of that, we're responsible for the HFEA, for the traffic light, for the add-ons, IVF add-ons, which I imagine we'll come on to. But also horizon scanning, what's coming out next. So a big hot topic at the moment is, and it's something which is upon us quite soon, is artificial eggs. It's making eggs from skin cells.
It's amazing, isn't it?
And artificial sperm. I mean, this stuff is not a long way off.
Wow.
So how should the HFEA regulate that? Because artificial eggs aren't eggs. They're outside of the law.
Sure, yeah.
How do you regulate it?
God, that's mind
That's
boggling.
just blown my mind.
Yeah.
That's
is,
incredible,
isn't it,
isn't it?
really?
It's happening. I mean, it is just around the corner.
Because there's a lot of talk about artificial intelligence
Yeah.
within the IVF community now already, and obviously EmbryoScope when that came in and all that kind of stuff. But this is the first I've ever heard of artificial eggs and artificial sperm.
So the term that's often used is rather than IVF is IVG. So it's in vitro gametogenesis, which means making gametes, which means making eggs or sperm. So at the moment within the law, and the problem is, as I mentioned earlier on, the HFEA makes sure that clinics follow the Act of Parliament, which is from 1990. No one had thought of artificial. It's not in
it's
law.
almost like an
that's
impossible
30
thought.
years ago,
outside
isn't
of
it?
it.
Yeah,
But
yeah.
in that law from 1990, it talks about a woman and her husband, just to give you an idea about how old-fashioned it really is.
Yeah.
So government are looking at renewing the Act and redoing it. So they asked the HFEA to send in proposals for how we thought it should be improved and future-proofed. But obviously, a lot of other stuff going on election-wise. So I don't know when that will happen.
Yeah.
That's absolutely mental.
That's crazy,
I just
yeah.
can't imagine. And I'm stumped. I'm absolutely stumped as to what
we
to
finally
ask.
muted.
Somebody else
Yeah.
stopped today.
Wait, somebody else asked
Toby
a
earlier.
question, but it's like, I don't know, but is that the way fertility treatment's going to go, or is there a particular time that sort of treatment is needed?
So, I mean, from a female point of view, a lot of this is focused on in vitro gametogenesis for eggs rather than sperm. But sperm, there's a lot of work going on with sperm at the moment. But just briefly from the egg side of things, as most people will be aware, women are born with 2 or 3 million eggs in their ovaries, and the numbers of eggs starts going down from before birth.
Yeah.
So the highest point is about at 6 months in pregnancy,
Yeah.
and then it's downhill from there. And then the menopause happens when there's 1,000 or 2,000 eggs left. So obviously some women run out of eggs earlier, and so what is being done in other species, but is basically at the point when this is going to be tried in humans, is taking stem cells or skin cells even, so a mouse swab, and then getting the DNA from that, doing various things to the DNA to make an egg out of it. So you literally then could make 100,000 eggs, 10,000 eggs for someone who's 48 years old.
Yeah. And so interesting.
amazing,
So if you did that with a 48-year-old woman, would that egg quality be 48 years old, or would that egg quality be completely different?
Yes, it's a very good question. So we still don't really understand why egg quality reduces in women as they get older. Sperm quality, genetic quality does reduce, but nowhere near at the same. Obviously, it's being newly produced all of the time, the sperm. But it's not entirely clear why the eggs are more likely to have the wrong number of chromosomes in as they sort of get older. So the companies there's three commercialized companies that are really getting into this field now of the IVG, particularly from the egg point of view. And the safety side of it is the bit that people are concerned about. Obviously, it's an outside, is because it's one thing doing experiments and saying, this artificial egg seems to be safe and fine, but it's another thing then you're making a baby out of that.
Yeah, what's
It's
the
almost
long term?
prospectively looking back at the babies born through that sort of technology when they're in their 20s, 30s, 40s, and what impact does that have
and
on
children's
their future
children.
health?
Absolutely,
Is the-
because once you change that, it's a new germline, and that's then going on and on forever.
Yeah, and it's kind of in some ways bringing this back to male fertility. We're only perhaps now seeing the impact of plastics and endocrine disruptors and all the stuff that's happened over the last 30, 40, 50 years.
Yeah.
I think really we're only just seeing that now in the massive decline in male fertility that we've seen. So, you introduce this technology, you're not going to know for another generation or two what it means.
Yeah, and I think on the male side of things, obviously there are men who don't produce sperm at all. So you can't even if you try to do a surgical sperm retrieval, there's just no sperm being produced. So this technology would allow those men to actually have artificial sperm made that would then be used as part of an ICSI treatment in an IVF cycle. But again, there's a lot of research in this area. I think probably more of it commercially focused on the female side, because there would be more for companies. There's more gain in it, I guess.
Always has been, hasn't there, historically?
But it's we had a presentation on this at the HFEA last year, and it's roughly my area, but I'm not a researcher in IVG, and I was stunned by how close this is.
Wow.
Yeah. And you can almost expect it in the sort of animal world. We've heard of Dolly the sheep and various other clothing type aspects, and I suppose it's in some ways very similar to those types of technologies which have been known for quite some time. But bringing across the bridge into that human germline and human species is going to be really challenging from a medical and ethical point of view for communities across the world. So
at the moment, in the UK, the law is about what you do to an egg and a sperm, and an egg is defined in law as coming from an ovary. Well, these things don't come from an ovary; they're not eggs. So they seem to fall outside of regulation. They've just been banned in Japan, so Japanese researchers aren't allowed to make artificial eggs and try and fertilize them. In the UK, it seems as though that will be possible, although whether or not research licenses are needed for that, it's all being considered at the moment.
But there's definite need there, isn't there, for looking at new technologies in the future, to overcome some of the challenges within fertility. We know that, fertility is in some cases is a disease, isn't it? It's recognised as a disease.
I think in all cases, it's I would consider it's recognised as a disease state.
Yeah, and from that point of view, there will be natural patients that fall out of that sort of cohort, which definitely would like to have children that can't have children, and it's a really difficult sort of subject matter, isn't it, to sort of to raise. And I suppose as these technologies come forward, and Dr. Google is out there sort of informing us of all the latest research, there's going to be some recognised demand for these types of technologies, and people watching over them, and in some cases a lot of investment going in, because there is a vested interest in looking at the future. So it's an
like
interesting space, isn't it?
This is. If it reminds me of a sci-fi movie, this does, kind of talking about creation of life like that. It's quite incredible, isn't it?
People will never have to have sex ever again. So it's like, well, just take a swab of my skin, stick it in a dish, and.
But so it was pointed out to me that someone, if they scratch someone walking past,
that's what I was thinking. How far do you take?
That's a good point.
You make DNA. You can make their eggs. It's also been looked at whether from if you get if a man XY, can you make eggs and sperm?
Okay.
Whoa.
So,
oh my god!
Because obviously you're having to divide up the chromosomes to make the eggs or sperm.
That's
so
scary,
this is all stuff that's being looked at, and this isn't a sci-fi. This could be looked at. This is all happening now in terms of looking at it.
Wow.
So your role then, not just you, but the HFEA, is having to look at all of this stuff and how do we regulate it? How do we protect patients? I mean,
the regulation again. So the protection of patients comes in from Parliament in the UK. So it's essentially.
So it's got to be passed by an act of law.
Absolutely. So it's so Parliament would have to look and think, okay, this is how we think this should be defined and regulated, and then it'd be up to the HFEA. Would advise Parliament on it, their view, but there would also be a huge public consultation, I'm sure, and sector consultation about these things.
Oh, it's that question. This came up in Edinburgh at the conference. It's like, just because we can, should we? Isn't it? This is one of those, isn't it? It's like, Really, really
Yeah,
tricky.
because I remember at that conference I was talking about space as well, and kind of like using technologies in space, and that was quite interesting. I didn't go into the seminar, but just hearing people talk about space and fertility in space, that's another thing that's like sci-fi movie stuff.
Yeah.
You know, it's
But even you mentioned about people wouldn't need to have sex to procreate. Another one on our list, and again, this is all people look at the HFEA SCAC part of it. This is all minuted and our sort of our agenda of hot topics and things. There's ectogenesis, which sounds very sci-fi. So ectogenesis is essentially culturing an embryo all the way through to live birth in the laboratory.
Wow.
So artificial womb.
wow.
Oh.
Yeah, I think I remember seeing something about that actually.
Yeah.
not too long ago.
So this is all again. This is people are researching this stuff.
Yeah.
Well, I
This
suppose
is
that
going
gets
on.
over the barrier of surrogacy, doesn't it?
Yeah.
I suppose if
Yeah.
you've got that type of mechanism in the lab to
It's
I mean,
exciting.
that seems
unbelievable,
pretty
isn't
sci-fi still at the moment, but these are all research areas.
Yeah.
AI that you mentioned is an interesting one. So how do you regulate AI? At the moment, AI is coming into, as in, as you say, time-lapse incubators and what have you. But again, it's all starting to happen now. There could be a situation where a patient can contact a clinic. The whole consultation is with a computer. The results from the AMH and DNA frag or whatever go into the AI system.
Yeah.
That then comes out with a protocol, dose, drugs, scan this day, decision making on when the egg collection has to happen. And you could easily have a situation where the only crossover is the person doing the egg
The actual
collection.
yeah.
That's quite
Stuff
scary.
goes into a time lapse, hands off. So who's then responsible if things go wrong?
Yeah.
But
You know,
where's
is it the company in Palo Alto responsible, or is it who's responsible?
Yeah, that's a really complex
Well,
problem.
they do
isn't it?
talk about IVF in a box, don't they, these days?
Yeah.
That's that formula right there, isn't it? IVF in the box.
But
And
where's-
that is scary, though, isn't it? Really, I mean, it is sort of it almost taken that personal touch out of medicine.
I was going to say, where's the patient care?
You know,
Yeah.
and
Where's that
exactly.
conversation with how you doing?
Yeah.
Because very much counselling, from the professionals in the field, it's very much a counselling thing along the journey, isn't it? You've got,
But you could do that alongside
Yeah,
the
very
whole
true.
AI thing I've spoken
Yeah.
to you about. You could still have a very friendly
yeah.
everything, but who's then legally responsible for the treatment?
Yeah.
wow.
Who's the overseeing
What a
clinician?
start to the podcast. Honestly, I didn't think we'd talk about that kind of
absolutely
stuff.
fascinating. Absolutely fascinating stuff.
And that's why I enjoy the HFEA work because it's
Yeah. I
I
really
bet you do,
interesting.
It's really like thought
Yeah.
provoking
Yeah.
stuff,
Yeah,
isn't
yeah,
it?
crikey.
Madness.
And what about, you mentioned obviously the traffic light system,
Yeah.
and they very recently launched their dashboard, didn't
Yeah.
they? So
Yeah.
tell us a little bit about that.
Yeah, so the traffic light system is an interesting one because that came in before my time on the HFEA, and that came in about 2017. So before that, what was happening? I mean, going back 2010, no one had ever heard of add-ons. There weren't really any add-ons. So patients would come into an IVF clinic and would just have a straightforward normal IVF cycle. Because there's nothing you could really bolt onto it. Blastocyst culture was just coming in, but it wasn't really considered an add-on. And then probably between about 2010, 2015, people started coming in saying, oh, well, I've read online. I think a lot of it is just social media online
word of
stuff.
mouth, yeah.
I've read about this clinic in America that's saying I should be injecting myself with this or adding this and or doing something else. And then there was a concern that a lot of doctors and clinics were overselling or over-promising things where there was no evidence, but there was a cost associated with it. And then about 2016, there was an undercover Panorama, BBC Panorama
Oh, I
program.
remember that, yes.
Yeah.
That it was, I remember watching it thinking, oh, I hope I'm not on it. But I knew I wouldn't be on it. I knew I wouldn't be on it. But I remember thinking,
Yeah, it's worrying, isn't it? Yeah.
and they did undercover filming. And then from there was then concern amongst the HFEA, but also the various fertility societies, including ESHRA and PFS and everything, that basically add-ons should be either regulated or at least looked at independently.
Give some guidance.
So the traffic light system came in, and then because I'm now responsible for that, we've sort of finessed it further in terms of how that works.
I think a lot of patients struggle with the traffic light system
Yeah.
because they're many of them are in a very vulnerable position, aren't they? When they
Yeah.
go for treatment, they want to try everything. They want
Yeah.
to chuck the kitchen sink at it
Yeah.
if they can afford to, and they go to the HFEA website, and most of the things are amber or red,
Yeah.
and they're like, "Well, do I do IVIG
Yeah.
or do I not?"
Yeah.
And it's quite a tricky system for them to
Yeah.
navigate. And I
Yeah.
think this perhaps, I don't know, correct me if I'm wrong, you probably know more. I think it probably reflects some of the issues around research and fertility.
Lack of research.
And lack of research,
Or lack of
especially on the-
funding and research.
and especially on the male fertility side. But it's sometimes very hard to
Yeah.
do research in fertility because how do you randomize and say to a woman or a couple, well, you can have this treatment and it might help, it might not, and you're not going to get this treatment, and we don't know what you're going to get. So how
it's
do you
interesting.
manage that?
Friends of mine I was at medical school with who work in different areas are just amazed when they look at IVF about the Wild West side of it, because that just does not happen. If you're a chest physician or a cancer surgeon, you're not trying things out that have had one really rubbish study published on it. It doesn't happen. Whereas within IVF, because it was commercialised, unfortunately, because the NHS didn't bring it in, it was pushed out in the private sector very early on in the 70s and 80s. It is a very commercialised area, as are some other areas of medicine as well. So I think the issue before, so you mentioned IVIG, so again, going back to before the first traffic light system came out, and I'd looked at the evidence for or against natural killer cell testing, and there was no evidence for it at all, like none. But clinics were doing it and were charging thousands of pounds to patients based on nothing scientifically, literally nothing. And then when the results came back as abnormal, which to my mind meant nothing, they were then being told to take drugs such as IVIG at great cost and risk based on nothing. So I'd be explaining that to patients. It's based on, they're saying, there's whatever clinic somewhere saying it's really good. And then it was my word against some other guy. I knew I was right because there's nothing there. And they were basing it on their 10 patients that got pregnant, whatever, which is anecdotal medicine. So then what happened was then, because it was an independent review of the evidence, looking to say, okay, well, is there evidence for natural killer cell testing and using IVIG? And there isn't, and there still isn't. Almost overnight, patients in my practice stopped asking for it because they were aware of it and because it was very clear that it's red, i.e. don't do it. And it made the conversation much easier. I don't mind having difficult conversations with people, but at least I could say, look, okay, there's an independent body here that has no vested interest in it. If it works, why are they going to say no? Don't do it.
Sure,
So it really helped that conversation. And you're quite right that at the moment most of the add-ons on there are sort of that ambery red, which basically means studies are either split, that they half show it works, half show it makes no difference, or grey on the new one just means there are no studies. But in some ways, I think that also does help. It adds impetus to people to do studies as well. And the NICE guidelines are the same. At the end of NICE guidelines, there's a whole list there of things that we don't know the answer to this. This is a good area to study.
But that sort of stimulates it should be studied. We're aware of them, and it may well be that in certain circumstances it is appropriate. However, the body of evidence for most patients or couples that are trying to conceive is probably not necessarily relevant and shouldn't be high up on the list of options that should be offered for clinics. So I think it does provide a really nice balanced way of communicating, saying, there are things that you may have read about, but this is what clinicians and a body of people have said. Actually, this is the balanced view. There's not sufficient evidence to suggest that
it doesn't mean you can't do it.
No,
and I think if patients want to do it, that's fine, but they shouldn't do it thinking that it's going to double their chance of success, because it just doesn't. If there are no studies saying this doubles your chance of success, it's wrong for a doctor to claim it does. Absolutely wrong.
It's a good protection, isn't it? Because like you said earlier, when you're a patient go through this space, you are really vulnerable because you will literally beg for any whim that it might work, and you'll just chuck everything at it. And certainly on forums and stuff, patients talking to patients, you'll hear a little thing that go out, some sort of old wives' tale, like eat McDonald's chips after an IVF cycle, and everyone.
It's a huge thing now.
Just because it might.
Just
because it might.
Do anything.
Put your legs in the air.
Yeah.
Just because it might, So it's it is. It's a minefield.
I think eating chips is a good one, but it doesn't cost anything. It doesn't cost you £5,000 and maybe delayed treatment or whatever. There are things that are done. You think, okay, fine, it's not going to cause any harm, but there are things out there that. A good example is there's a thing called ERA, so endometrial receptivity testing. Which the recent studies shows if you do that, it lowers your live birth rate. Not that it doesn't make a difference, it lowers your live birth rate.
Right.
This is being sold commercially by companies.
Wow.
Is that the same as endometrial scratching?
No.
So this is a different test.
This is actually So if you do an endometrial scratch, you're putting a sort of catheter or straw through the cervix. You created temporary damage to the lining, which again, 8 years ago, every patient was paying £300 to have a scratch. The studies have come through showing it does not work.
Really?
It doesn't do anything, as is shown on the traffic light system. So hopefully very few patients now are having this uncomfortable painful procedure that they're paying for.
Yeah.
What you can do when you do that is you can take some of the lining of the womb away, endometrium, and they do genetic testing on it. The idea is you're trying to find if there's a correct implantation window. So logically, it makes sense. Some women, the company that invented it, a Spanish company, said that a third of women, the window of implantation when we put the embryo back for that woman should have been shifted a day or so either way.
Right.
Logically, it makes sense.
Yeah.
But then they started selling it.
That's the
Yes.
receptivity.
They started
of
selling
accepting
it.
the embryos.
And people kept saying, well, it's great, but where's the study?
Yeah.
Oh, it's coming, it's coming. Where's the study? It's coming, it's coming.
Yeah.
When it came, it was a bit of like okay, well, that's not a very convincing study. And then there was a much bigger study from the States with no commercial interest in it that showed half patients, all the patients had the assay done, but only in half of them was the result revealed and used.
Okay, so it's more like a blinded, half-blinded
properly
test.
properly blinded. It was properly blinded. So it was only at the point of the pregnancy test did they actually look back? Did patients find out? Okay, they all had the result, but half of them the result was ignored, and half of them it was shifted. The shifted significantly lower live birth rate.
Really?
Yeah. So that removes the bias really from a clinician's point of view of whether you should offer it or not.
So I think it's a perfect example. Just because something sounds good doesn't mean it's good, and it might actually do harm.
Yeah. Yeah. And there's plenty of examples of that. I think when I sort of first introduced antioxidants and supplements into the male fertility world, many years ago now, so it's over 10 years ago, it was almost like a shotgun to fix something, because you've got idiopathic male infertility. Well, we know now that over supplementation of men that don't need antioxidants is equally as damaging as the people that receive them. So it's all about getting that body of evidence and trying to do that extended research from where companies start and continuing to evolve the body of knowledge and knowing exactly which patients are going to be suitable for options and which ones are definitely not. So these differential diagnostics are really, really important to get right, aren't they?
Yeah, absolutely.
And is there much going on in from that regulatory HFEA side around male fertility? Kind of where do the HFEA sit in that kind of side?
Yeah, I mean, I was involved with the NICE guidelines 10, 12 years ago. So the current NICE guidelines they're all sort of going through again at the moment. I spent 3 years on that committee putting those ones together, and it's certainly fair to say when there was a urologist involved in it and an embryologist, but there wasn't a lot to say on the male side, particularly back then. This is 2010, 11, 12.
Yeah.
Apart from ICSI, there wasn't really anything else that was being done, to be honest with you.
There's very little research, actually.
Yeah, no,
and
very
certainly
little.
very, very little UK research, funded research.
No, absolutely.
There was there was a number of funding applications, but then never really got off the ground. So it's been really, really challenging from that point of view. But you roll the clock forward and you think, crikey, there is quite a number of technologies which actually have been around for quite some time. I'm talking about diagnostic tests that really hadn't seen the light of day and not really utilised. And it's probably a lack of research that has stemmed.
I think it's lack of research, and it's probably just for various reasons a focus more on the female side within a couple.
That's right.
I think some of that's because traditionally, for whatever reason, fertility clinics have been within a gynecology setting in general. But the current NICE guidelines, which are being worked through, and I was involved in some of the early work, the scoping side of that, it's very clear there's a much more of a male focus in that work. Absolutely good to hear.
Well, we've seen it from some of the bodies, haven't we? Think that like ARSM, which is the American Society of Reproductive Medicine, and ESHRE and WHO. We're now starting to see emerging sort of information coming forward about the importance of doing some extended tests in male fertility, especially where you've got conditions like recurrent miscarriage or recurrent pregnancy loss and miscarriage and other sort of issues in the embryology line. I think we are starting to see a body of evidence which is emerging that is suggesting that we should possibly look at male factor infertility a little bit more than we have in the past. So
I think
it's good to know.
From an HFEA perspective, and answer your question, so for the add-ons list, because there's a ESHRE guideline, you mentioned ESHRE just now, but the ESHRE guidelines are coming out as well. They've got guidelines on add-ons with loads more add-ons because they've basically just thought about everything and just put everything on a big list.
Right.
The way the HFEA works is anyone around this table can think, do you know what, this product or this technique, I think I would like the HFEA to look at this as an add-on. And then there's a form you basically fill out, and then that goes through and then it's put on as an add-on. But so diagnostics really fall outside of it because it's really things within a treatment cycle. Because it came in because people were
Protect
doing
people,
IVIG or whatever during a treatment cycle, whereas things such as supplements or even DNA frag, it's not really an add-on.
No,
it falls outside of that.
Yeah, it's an extended sort of test, isn't it?
Yeah.
I mean, what's interesting now, because we've got various aspects of looking, and certainly I'm involved with some of the research, looking at sperm selection. There's a number of new devices that have come out, which is almost trying to look at a more what's the best way to describe it? A more simplified way of separating sperm rather than using traditional methods of centrifugation and so forth. Have you got any idea? I mean, in my mind, it forms into two camps. It's a sperm preparation method, but it could also be considered as a treatment as well. In certain instances.
So I mean that definitely would fall into being the add-on side of things. So the whole AI, which you mentioned earlier on, is all over that area in terms of sperm selection. For ICSI particularly. Which can a computer be better than an embryologist in checking the right sperm to put back, possibly. So there's a lot of research in that area, and that would be considered an add-on. If it was just looking at
just a different sperm preparation method where you're avoiding the traditional.
Possibly if it's sperm preparation for actual egg insemination. Then yes, I think that probably would fall with an add-on because you're changing something.
No, we've got interesting research coming out on that, sort of looking at different ways of separating sperm through channels and microchannels and so forth. Microfluidic type activity. So it's going to be interesting to see if that actually helps identify or concentrate sperm with good DNA integrity from, looking at things from either a morphological point of view or IMSI and various other things, and saying, right, is there a different way or is there a better way of isolating sperm for sperm, so sperm preparation for an IVF type procedure? So
PIXI and IMSI do fall within the add-on, so that is on the
radar,
and that's sort of different techniques of selecting sperm essentially.
So,
it's all really amazing, this stuff though, isn't it? Like from me being a patient, having gone through the process, knowing now kind of almost on the inside, I've kind of been to some of these conferences and learned the science and what we're talking about now. It's so reassuring to hear what's being done to protect patients from the HFEA side of things, but all of the research that is still needed, but more research is being done, and there's a real provenance to focus on men, but really to look at couples properly, right? To look at equally looking at male and female, and how can you ultimately get an outbirth or live birth. For me, it's such a reassuring thing to have as that patient voice, just to know all this work's going on. And I think when you're a patient in the fertility sector, you're kind of a bit of a rabbit in the headlights going into an IVF clinic or whoever you're seeing, and you have no idea all this stuff's going on. So I love to really learn as much as I can in this space to tell people just what great work's being done, because ultimately there's so many people in this space that really care for the next baby or the next couple that should be able to have a child.
Well, that's why we're doing these podcasts,
absolutely,
isn't it? It's really to try and raise awareness, try education, and point people in the right direction for the great advice that is out there, so they can make more of an informed and concerned decision. So absolutely,
because it is a complicated space. For the average
certainly
human being,
for men, it's
but for the average human being in the space of fertility, I mean, when I first was sort of going through my, I think when I first had the first sort of IVF clinical appointment to talk about what we were going to be doing, we'd had a basic idea of various things, because obviously Dr. Google is it's the place you go when you're unsure, but it was like learning a language, and we were so overwhelmed, not just the emotional side that we were dealing with, but actually just all this stuff we've got to learn. And suddenly you're at home with needles and injecting, and you're like, what is going on? And I remember when I got to my kind of lowest ebb and I really hit rock bottom and had my counselling, the trigger for all of my kind of anxiety, emotions and depression I had was getting the needles prepped for Katie, because it was like that moment was like, is this how we're going to have a child? We just want one naturally. And of course I went on to have natural conception, which I'm so grateful for because of the science that's kind of around these days. But what I'm trying to get to here is that there's behind the scenes, there are so many good things happening for the better of patients, and it's so nice that we've got testing that we can kind of vocalise that and talk about these kind of topics.
And do you think the landscape's changing, Tim? Because you mentioned the NICE guidelines, and that it's perhaps becoming a little bit more focused on male factor, because I think we have seen such a huge change in sperm quality over the last 4 or 5 decades.
Yeah.
Is that pushing part of the change and the landscape changing, do you think? Or
I don't
is there
think
more
so
to come?
yet. To be honest with you, I think the recognition of the significantly worsening sperm quality, because as you'll be aware, there's been papers suggesting it for quite a long time.
Yeah.
There's always been reasons given that the papers might be wrong. Was the counting method used in 1950 different to the one used in 1990? Is that why there's a difference?
Yeah.
Was the population, you're comparing different populations, So there was a lot of question marks about the validity of the evidence behind that. Yes, there was a difference, but was it a real difference?
How big of it?
Whereas
Yeah.
more recently, it's pretty convincing because the quality of the studies is so much better now, and that there is, for whatever reasons there are, and you mentioned some of them, why there might be a big reduction in count, motility, everything really. I don't think that is involved with driving forward any change yet.
No.
I think there's an increasing awareness that there is an issue and it's going to get worse. The question as to whether that issue, that reduction, has actually caused more people to come into fertility clinics, maybe not though, because men can actually get away with a relatively the normal range for sperm count is so wide.
Yeah.
It might be 15 up to 300.
Yeah.
Yeah.
That even if a big proportion of men get a reduction, then for that man it might not actually for him make a difference yet. But
I
clearly
suppose
it's only
if you've
going
got the
one
ones-
way.
But if you've got the
There'll be
ones at the
some people.
bottom,
I agree. I agree. But if you had a 50% reduction in sperm
from 300,000,
it's not
300
for
million,
most people. It's actually not yet going to make a difference yet.
Yeah.
Obviously, for some people it will, but it's obviously concerning. It's happening absolutely. So I think in terms of answer to your question, I think there is more of a focus on the male side.
Yeah.
I think it's partly because there's just more research happening in that. There's more products available. There's probably more demand from men to actually be part of the conversation as well.
which
Quite
really
rightly.
needs to happen.
Absolutely.
Yeah, and I think some of the gaps is that what I haven't seen is really a progression in the types of diagnostics that's been available. We know about normal semen analysis and so forth, which has been the mainstay, and it will always be the mainstay of basic sort of fertility assessment for men. But there are emerging technologies, and I think one of the difficulties I've seen in the UK is there's very few companies, UK-based companies or companies outside of the UK, that have actually tried to look at investing in those technologies and making them more available, accessible, doing the research, and then actually challenging and putting submissions into NICE, for example, about the new technologies and looking at cost effectiveness of introducing these diagnostics into mainstream practice. And until companies do that, we're not really going to change, the influence of success in the NHS sector, and certainly will have an impact on the private sector as well by not being able to have these sort of diagnostics available. So I think there is, in my mind, is a plea really to say, right, we know there are diagnostic assays out there. Let's try and get them incorporated, not only in a research project so we can show cost effectiveness to the health bodies and the health insurance, but also to actually make it more accessible for guys and couples as part of their basic tests to introduce.
But it is really important, coming back to what I said about the ERA testing, for the woman's uterus. If tests are being done that then lead to a change in management, it is important to show that the test is worth doing. An issue with some of the testing, the DNA fragmentation testing, has been the wide range of different assays, which you wouldn't know much more about than I do. The different assays of different levels of quality. So by different assays, I mean different techniques for testing it. Some being better than others, but perhaps all of them being commercially available. Well, which one does a patient go to or a lab go to? So I think
that's it, and I think it's always got to be the physician's choice. I think the physician needs to know and understand those assays, and I think that's one of the things that will be driving, certainly moving forwards as we've introduced assays. We've got two of the leading ones, which are in the WHO, but it's a matter of educating the physicians to understand what are the assays measuring, what is the influence of that, and what management change is that going to look at? What are the algorithms for working men, and whether they need a medical treatment, a true medical treatment, or whether they can look at some of the causal influential factors, things like lifestyle and nutrition and exercise and so forth, which may be easily modifiable, which doesn't cost doesn't cost the purse, doesn't cost your back pocket at all if they're getting the right sort of counselling and the right advice to get their fertility health in the right order. But I think there are certainly conditions out there where these diagnostics can identify as a differential diagnosis a true medical root cause which needs treating.
Yeah, I agree with you.
So I think it's really exciting. So that's what we're investing in. That's why we're doing what we're doing. It's not only saying what we're doing, but actually putting money where our mouth is in terms of getting that evidence base and encouraging people to work with us, collaboratively, truly collaboratively, and to look at how we can improve those diagnostics and treatment.
So I'll ask you a question. So what sort of work are you doing in the DNA fragmentation area? What sort of work are testing?
So we have been focusing probably for the last 4 years on some of the the leading assays. So we've got an acridine orange functional test and also the tunnel assay. So for people that don't know, there are particular assays which we're looking at flow cytometry, looking at thousands of cells, sperm cells, that we can tag in a particular way to look at areas of damage, the gamete damage in the bases, and those types of research both at Imperial College in London, we put flow cytometers in there, and at the University of Kent. We've been looking at not only verification and validation and cross-validation of assays that are used in the US, for example, and elsewhere, to make sure that we've got the very best results. But we're also looking at the impact that it has on the diagnosis of patients as well. So we're working with leading physicians, urologists in particular, who are, really been interested in what do these diagnostic markers look like, and does that actually change their view of treating patients? And things like, for example, patients that may have a varicocele. There's been a lot of controversy over the years, I think, about whether, for fertility, whether you should treat it or not. And I think it's one of those diagnostics tests that if you don't have high DNA fragmentation, but you've got a varicocele, you probably don't want to touch it. There's no medical reason for touching it other than whether there's a pain associated with it. But for those patients that do have a varicocele where it is actually making an impact on their fertility health by heat scrotal stress or other damages that the higher levels do, by using that differential test and knowing whether it has had an impact, then that could give you the rationale for a cost-effective medical intervention such as embolization for treating varicocele and trying to restore that male factor, which may go on to have issues, especially if you're going through IVF, you're still getting repeated IVF failure, and it could well be because it's just the mechanics are just not there enough and needs medical treatment. So I think we've seen a body of evidence latterly in the last couple of years that to suggest varicocele repair for those patients with high DNA fragmentation can be very, very effective, but maybe not effective at all for those that don't have any DNA integrity issues.
No, it's good. It's good to hear that you as a company are putting your money where your mouth is on this and actually funding work into it, because I think there has been an issue in the past with other companies literally just selling a product and making claims that are based on nothing at all.
Yeah.
I have an issue with that, because if I'm advising someone to go away and if it's eating McDonald's chips as mentioned, that's fine. But if it's something that's then adding in extra layers of treatment, and I don't mean taking supplements, but having surgical sperm retrievals or something, quite aggressive based on maybe an unvalidated test, that could be a bit of a problem.
That's right.
So it's really good to hear that you guys are working with good universities and good people as well to try and get.
I think that's the important part. It's not only doing the research, and we had a researcher in just before, didn't we? That's actually got a PhD and spent quite a bit of time in trying to validate assays and so forth. But if we're going to move medicine forwards, and it's always slow, isn't it? I think incremental improvements in medicine, that we've got to do these things correctly and work out what is the appropriate route of using these tests versus the inappropriate route.
All about the patient.
And it's all about the patient.
Exactly.
Yeah. And information is knowledge. Knowledge is power. So
just the same as you said with antioxidants. It's like as Test Tim, we could just sell antioxidants and just say, right, there you go, everybody have them. It's like, well, that they're beneficial for certain groups, and they're beneficial when there's evidence that you need antioxidants, but they might be detrimental if you don't need them. So like, it's doing the right thing for the patient, it's doing the right tests and at the right time as well, and then giving that man knowledge, information, and the right treatment pathway, rather than just selling something for the sake of selling something. So you know, it's getting people informed and knowledgeable, and it's, I always think anything medical, probably anything in life, you've got to make an informed decision. And I think, you know, this is what you're saying with the HFEA, with the traffic light system. You've got to look at the evidence, you've got to understand what you're making a decision on, and what is all the evidence. And I think we're really keen to make sure that men are properly informed, properly tested, and know what to do with that information.
And that's really important. It's really important for me, you know, as a biomedical scientist a long time ago, moving into industry. You know, it's always got to be backed up by clinical science. And as a male infertility patient as well, I've been intrigued about, you know, why is there not enough diagnostic tests, but more importantly, why is there no sort of follow-up treatments either? Because, you know, when I was going through it, being told that I couldn't have children and then the only option was donor sperm, it was like, crikey, I don't know I'm ready for that, you know, mentally and so forth. And actually, you know, if I roll the clock back 20 years with the technologies that are available now, which actually was available 20 years ago, it may have made a different informed decision for us as a couple. So that's driving me is a good clinical scientist knowledge. It's got to be informed, and it's got to be balanced by cost-effective opportunities.
And I thought, you know, as a company as well, obviously by doing that, you know, the primarily thing, as Toby said, is you're doing it to help patients, but commercially it's going to make sense as well, because you are going to be seen out there in the sector as a company that's doing things properly. So it's win-win.
Absolutely.
And we just reinvest the money back into research, and I think that's what we're doing. A very big part of what we do as a company is reinvest, so that we can improve upon the diagnostic assays that are coming through and need to be tested thoroughly before they're introduced into the marketplace.
And we've touched on education quite a bit here. Let's talk about your lives. Your Tim Child Lives.
Instagram Lives, it was new. I mean, fairly relatively new. I'm not really the Instagram generation as such. I'm like young Toby.
You did a
He is of Toby's generation.
That's right. Noted, Tim. Noted. But he is 15 years my minor, and he has had to teach me a few things on Instagram.
So obviously, got kids are all over Instagram, and so I decided I'd been thinking about it for a while. So the background to it is when I was working in Oxford in the IVF clinic there, twice a month I would do a patient information evening. The pre-COVID was always in person, and I always enjoyed it. You know, I like speaking with patients and couples, and so it was always and I never used slides. I would always just talk to people, and then we had a few pictures of like quite arty pictures of eggs and sperm and embryos on the wall, you know, sort of cherry blossom type pictures and whatever. And so I'd always did that, and then something like the 15th of March 2020, we thought, okay, well, we can't hold our opening. I said, and that morning I said, well, let's just do it online. You know, as you remember, even back then, trying to get Zoom working was impossible. So I thought, let's give it a go. And then I switched into doing them online. So I did really two a month all the way through lockdown, and was doing that until I left TFP in October. And I really enjoyed it, because I'd say to the patients, there might be maybe 15, 20 couples or something online. Any questions, just type them in. So it probably took me 20 minutes to go through my spiel bit. And then I'd get into the bit which was more interesting for me, and I think probably for them, about these questions. And what I always said was, even if you think this question probably isn't of relevance to other people, it probably is, because it might not be now, but it might be in the future, or there'll be an overlap. And I really enjoyed them. So a year or two ago, I thought, well, maybe I should start doing something myself for that, separate. And I sort of didn't do anything about it. And then anyway, just before Christmas, I thought, okay, now I'll give it a go. And so I'm trying to get a mix of, initially I thought I'd just do it by, you know, interviewing people. So I was going to get Toby along to one of them and just do that side of things. But then I thought, well, that's great, except I also think people asking questions about, I've had 5 failed IVF cycles, or I've got male factor, what should I do? Like I was doing with the IVF Q&As, might be beneficial. So what I've seemed to be settling in on is a bit of a mix, really. So I did one yesterday in interviewing an amazing person called Sophie Martin, the infertile midwife, by her book. So I did one yesterday, interview or a chat with her, a bit like we're having a chat now. And then next week I'll be doing just a Q&A one. So I've asked people to send in tons of questions, and and some of them, they're generally ones I've heard before, but I'm very aware that other people will not have heard them. And some of them are literally, okay, we've spent 6 months trying to get pregnant. What do we do? All the way through to I've had 10 IVF cycles, not a single pregnancy. What do I do? And everything in between.
Wow, that's actually really rewarding. It's always good, like, obviously me and Toby, that date in March is in our minds because that's when we started the support group, many years ago, and just having that time with patients and just to help navigate, or help them navigate and answer their questions is really, really
and it's
great.
a privilege as well, isn't it? And we, through that support group that we used to do, it was a real privilege to actually listen to some of the stories and the journeys that people have been on and go, crikey, we just need to hold your hand here and just say it's okay. It's actually okay to not feel very okay.
Because it's difficult.
Because it is difficult and it is challenging. You're trying to balance all your emotions and your partner's emotions and so forth. And having that sort of ability to reach out to patients is really, really important. And, it's certainly important to us, which is why we're going to start doing our own support group again, isn't it, next month. So,
but it was interesting talking to Sophie yesterday, because I said to her, okay, well, I'm obviously someone coming from a background of running IVF clinics and the groups and what have you. What changes should we be making within running IVF clinics, you as a patient? And she said essentially continuity of care as much as possible, which is difficult in a big clinic with 70 staff. I mean, you try as much as possible, but that's difficult. But then the second thing she said, which is very relevant for today, was involving both partners if it's a couple.
It's a couple
and I said we used to hear that all the time because the person going through the actual treatment, the injections, as Toby said, is obviously the woman. And even if it's a same-sex female couple, there's one person normally going through the treatment as such. And what tends to happen within clinics is, that even if there's a couple in the in the waiting room, just the person receiving the injections, her name will be called out. The focus, unfortunately, is often on that person. As you said, the testing on the male side of it the result might be, okay, sperm test is normal. Right, over to you on the female side. And so I completely agreed with Sophie, and I said absolutely. And it's something that we often had discussions within our clinic about the real importance of making sure that if a couple are being treated, that both people are involved in that. That if there's some scan results coming through, they go through to both people, not just one side.
And we've heard lots of stories about that, isn't it? Where guys have had a semen analysis and it's the partner that's had the results revealed to them, and it's like,
exactly.
I'm
one of them people.
So it's not uncommon, but just the simple things that you could do in the waiting room in the fertility clinic by asking both partners to come to the reception. Right, we're going to take you down, and that I think is just just simple things that can make a big difference.
Even just eye contact, because again, we would get people complaining, saying during the conversation, and I don't think it was myself, but the doctor was just purely talking to the person having the treatment, and then the other person felt like a spare part. And that's a really easy thing to stop happening. It's just to go backwards and forwards and look at both people.
Basic things, that is. It's really
it's basic. But it makes a difference for people. It costs the clinic nothing. You can spend all the money on AI and all sorts of things. You forget the really basic things about welcoming both people in, looking both of them in the eyes, involving them in decision making.
But I think in fairness to the professionals in the space, it's quite hard, or I'd imagine it'd be quite hard, because when you do something day in, day out, you can kind of get a bit blasé, and it kind of gets a bit diluted to what that emotion might be. But when you're a patient, this might be the very first time. It's like Armageddon. This could be we never have children, and it's the world's ending. It's a massive deal. So there is definitely a kind of a balance there. And something from my experience, I didn't have necessarily some of the best experience as a man in those rooms. I did feel a bit isolated, but equally I didn't really empower myself to involve myself in the conversation because I just wanted to ignore the problem. So there is a kind of it's on both parties in some respects, and that's partly some of the work we're trying to do in Test Him, is to try and empower men to feel a bit more empowered to actually ask questions and be more involved, because it's so easy to sit there in silence and just try to just ignore what's going on, because it's such a.
I mean, a lot of women in that situation. A lot of women will say, well, they don't really understand their own reproduction, because at school the whole thing was about not getting pregnant, not about how can
family
you get
planning.
pregnant. And unsurprisingly for the guys, even less knowledge, obviously, about the female reproductive system or whatever. So I think often it's overwhelming for the man and the woman, but probably even more overwhelming for the man, thinking, God, if I ask a question, am I going to sound really stupid?
And that's what you don't
and they
want
don't
to
sound stupid, because every question is not stupid. Every question is a good question. It's not a stupid question. But I can see why people think, I'm so far out of my comfort zone here.
And again, I think it comes back to what I said earlier. You're kind of thrown into this space with this whole language and this lingo and this way of working that you're just like, what the bloody hell to say? What do I say? What's the right thing to ask? I have no idea. You're just trusting that the person in front of you is doing their best to ultimately get you a baby, which is why you're there in the first place, isn't it? It's a strange old space, isn't it, for patients, for sure.
Yeah.
It's been a fascinating conversation. I mean, kicking off with artificial eggs and sperm must be, we never knew that was going to...
Ectogenesis.
Ectogenesis. What sounds like something that Ghostbusters
It
like
does,
to do with.
Proper sci-fi.
Yeah.
So, Tim, where can we find you? How do people reach out to you?
So at the moment, the easiest thing would be the usual sort of LinkedIn and Instagram with Dr. Tim Child, so DrTimChild, Dr. Tim Child. I'm reachable on there.
Reachable.
Brilliant.
Yeah.
Excellent.
Brilliant.
That's really good to know, isn't it? Because the more people that know of who is around, that really good voice out there is really important to patients. I think to couples that are looking to try and get the very best advice and not just rely on Dr. Google, which sometimes will spin you into all sorts of different angles. But it's really, 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 really important to do. So big thank you, Tim, for coming in today.
You're welcome. Thank you for having me
Some
here.
time
Thank
out
you.
today, and good luck with the racing.
Yes, we forgot to talk about that, didn't we?
Yeah.
Absolutely.
Yeah.
We'll have to get you in just for a special racing podcast.
Yeah.
perhaps.
Maybe we should do that.
Yeah.
Well, Tim and I can set up a podcast just talking about racing, maybe.
Yeah.
We'll just bring all the trophies in. It'll fill the room, won't it, between the two of you?
Yeah, we can do that, definitely.
Yeah.
I think we should do that.
Sounds good.
Somewhere exotic, like Donington or Silverstone.
Yeah.
I thought you were going to invite us out to Monaco then.
I thought.
We can take this all with us. Yeah.
Absolutely. No, thank you so much, Tim. It was
You're
a
welcome.
real honour to have you on our podcast. And good luck with the rest of your career.
Thank you very much.
Thank you.